Well, welcome everyone to Grand Rounds. I'm Sebastian Tong. I'm on the Grand Rounds Planning Committee, and I'm really excited about this month's Grand Rounds speaker. Our speaker is Dr. Claire Simon, who's a clinician researcher with us in the Department of Family Medicine. She is double boarded in family medicine and addiction medicine, and completed all of her training at University of Washington from undergrad through residency and fellowship. And she focuses her research on substance use, community engaged research, and practice based research. And today she'll be talking to us about the evolving role of primary care in addressing opioid use. So, welcome.
Thanks, Sebastian. Kyle, is the sound good from my mic? Okay, great. Hi, everyone. Thank you for being here. Can you get my slides pulled up? Perfect. Oh, okay. Perfect. Well, I had a pretty first slide, but it's okay. I have no disclosures. We'll start with that. There we go. Buprenorphine saves life. That's a preface of everything. Okay, next slide. No disclosures. Next slide. Sebastian already introduced me, but like you said, I do family medicine and addiction medicine. And I've been working with the Harborview office-based opioid treatment program since it started in 2015, when I was a first-year medical student. Currently, I practice at Harborview. I do family medicine and addiction medicine consultation there. And I also work at the King County Low Barrier Buprenorphine Clinic, the Pathways Clinic, that's located downtown above the Needle Exchange. And like Sebastian says, my research is focused on improving outcomes for primary care patients with substance use disorders, and I use community-partnered research methods. Next slide. So objectives for today are to review the neurobiology of opioid use disorder, to recall the diagnostic criteria for OUD, recognize trends in opioid overdose deaths, understand the role of primary care in OUD treatment, distinguish between OUD treatment options, examine disparities in access to OUD treatment, and then also adapt best practices for patients with opioid use disorder. Next slide. So we'll start with a discussion of substance use disorders and addiction in general. So the way that we think about addiction has really changed a lot over time. The AMA in the 1950s was really the first organization to define addiction as a primary disease process and not just the symptom of something else. And then we've, kind of changed along the way and come to where we are now, where we think of addiction as a chronic medical condition, just like we think about diabetes or hypertension or other things that we treat in primary care. Next slide. And we know that addiction's complicated, and there's a lot that we still don't understand about it. And there are a lot of factors that go into addiction, and there's no single factor that determines whether a person who's exposed to a substance will go on to develop a substance use disorder. And this slide, I apologize. I know that we're not neurobiologists. We're primary care people, but I think there's a couple parts of the brain that are important to kind of have a vague understanding of when we're thinking about addiction. The first part of the brain is the nucleus accumbens, and this is the reward system of the brain. And this is important because substances like opioids release a huge amount of dopamine into this part of the brain, more dopamine than like any other thing could release. And this is very reinforcing, and it causes the brain to want to do the thing that led to that release again. And so that can reinforce the cycle of substance use. The next part of the brain involved is the amygdala. This one kind of works in the opposite way. So this is the fight or flight system of the brain. And substances generally decrease activity in this part of the brain. And this produces relief from uncomfortable feelings like fear and anxiety. And again, this can reinforce the behavior that led to that relief. And then finally, the prefrontal cortex, the only part where I actually know where it is, regulates the reward systems, and it can begin to work less well in addiction. and make it harder to regulate the other systems involved. So shifting gears to talk about opioid use disorder specifically, I think a key thing to keep in mind when we're thinking about this that we often forget is that opioid use disorder is really about the negative impact that opioids have on a person's life. It's not about using the opioid itself. And I think that's something that we often forget when talking about this. Next slide. Oh, yes, this is the one where there's lots of clickies. Perfect. One more. Perfect. Okay, so because of that, we diagnose opioid use disorder based on the DSM-5 criteria. And so there are 11 criteria for opioid use disorder. And basically the number of those criteria that you have determines the severity of your OUD. So 2 to 3 criteria is mild use disorder, 4 to 5 is moderate, and then 6 or more is severe. And I think it's helpful to kind of break these criteria into categories to make them easier to kind of comprehend. And so the first category is really about impaired control. So using larger amounts over a longer time than intended, a persistent desire or unsuccessful efforts to cut down or control opioid use, or spending a lot of time obtaining, using, or recovering from using opioids. The next category is craving, straightforward, craving, a strong desire or urge to use opioids. The third is social impairment, so not being able to fulfill obligations at work, at school, at home, continuing to use opioids despite problems at social problems or interpersonal problems, and then giving up or reducing important activities in your life because of opioid use. And then the next one is risky use, using in situations that are physically hazardous, continue to use despite harm. And then finally, there's physical dependence. And this category doesn't apply if you're getting prescribed opioids, and this includes tolerance and withdrawal. So I think, oh wait, go back one more. Okay. So like this kind of breaks it down, and it kind of a little bit demystifies like what actually is opioid use disorder. And I think on one hand, it makes it easier because we can kind of go through these things. But on the other hand, it's like, it's still really hard, I think, especially when folks are kind of in that mild area. It's actually, I think it's quite hard to actually diagnose opioid use disorder when people are in that mild area. Okay, now we can move on. Perfect. So I'm sure everyone knows that we are in the midst of an overdose crisis, starting like 2015, but kind of sometimes people say 2019, we started seeing this huge increase in overdose deaths. And this is very concerning to us. And the good news is that we've started to see things level off a little bit in the past few years. I think important to keep in mind that the overdose rates are still at an all-time high. So it's not like we can just, say we're over it. Like it's still a big issue, but they're not increasing at the rate that they were previously. Next slide. And like when you break it apart by state, it's actually very different in the various states. So in this map of the US, the blue states saw a decrease and the purple states saw an increase. And if you look at Washington State and Oregon, we were actually in the category who still saw a significant increase in overdose deaths. So we're a little bit behind the curve in terms of things leveling off. However, some provisional data from the last year has started to show that things are actually getting a little better in Washington as well. So that's good news. Next slide. And unfortunately, there's a lot of racial and ethnic disparities in opioid overdose in this country. American Indian, Alaska Native people have the highest rates of opioid overdose, and Black Americans have the second highest rate. And so one might ask, like, why did this happen? Like, what is going on? What led to this huge increase? And I think it's complicated and there's a lot of factors involved, but there's two that I think are particularly important that I want to talk about today. And the first is changes in the drug supply. So we've seen a transition to a drug supply that's predominantly high potency synthetic opioids like fentanyl, pretty much just fentanyl. And so we went from that being uncommon to that being like pretty much all that anyone is using. And the next is polysubstance use, specifically opioids like fentanyl combined with psychostimulants like meth. So a lot of folks are using these together intentionally to balance out each other's effects, like an upper and a downer. But then there's also a lot of contamination. So a lot of fentanyl contamination in psychostimulants. So folks who are not trying to intentionally use fentanyl who end up being exposed to it. And that's super dangerous because these are people who generally don't have tolerance to opioids. Next slide. So this graph shows changes in the drug supply. It's showing the type of opioid that overdose deaths can be attributed to. And you can see starting in 2015, fentanyl just took over, and now fentanyl is pretty much causing all of the opioid-related deaths. And then this graph shows stimulant-related deaths. And that middle line is, so the top line is all stimulant deaths, and the middle light green line is psychostimulants and opioids. So you can see the big increase in deaths related to psychostimulants was because of psychostimulants and opioids being used together. So what is the role of primary care in all of this? I think this is when things start to look a little bit more potentially positive. So of folks who need addiction treatment, less than a quarter of them get addiction treatment, but 60% of those people had a primary care visit. And so primary care is really a really good opportunity to identify substance use disorders and offer people help, and it's often quite underutilized. Why address substance use in primary care? I think there's two big reasons. The first is that it's super common. 25% of primary care patients have risky substance use, and somewhere between 5 or 15% actually have a substance use disorder, and this is probably higher in safety net clinics. And also, we know that providing treatment in the context of regular medical care can improve people's health overall and increase treatment engagement. So I want to talk a little bit more about the Harborview OBOT program, because I think this is a great example of addressing substance use in primary care. So like I said, OBOT started in 2015 at the adult medicine clinic at Harborview. And really, it was just a group of PCPs who are super motivated to think about how can we do a better job of taking care of people with substance use disorders in our clinics. And so they built this program that used the Massachusetts model from Boston University. A lot of the addiction innovative stuff that we do comes from Boston University. And it includes a nurse care manager who essentially provides care management for patients who are on buprenorphine. And so this model is kind of loosely based on the collaborative care model that was actually developed here at University of Washington for anxiety and depression. And so since 2015, our OBOT team has grown tremendously, and we now have a very interdisciplinary team with lots of folks from other disciplines besides physicians and nurses, such as counselors and even peer support specialists. So talking about OUD treatment options, I want to start with an overall framework of what our goals of OUD treatment really are. And so there are many of these. The first is to help people reduce or stop their substance use, depending on what their goals might be. Support people to actively participate and engage in treatment, restore their physiologic functioning, improve their quality of life and health outcomes, and really just help people to create a life that doesn't revolve around substances. And like I said earlier, we know that opioid use disorder is a chronic medical problem, but that long-term recovery really is possible. And we should strive to provide treatment that's evidence-based, patient-centered, comprehensive, and compassionate. So there are 3 FDA-approved medications for opioid use disorder. I'm not going to go into great detail here, but just want to briefly review these. The first is methadone, which is a full opioid agonist that can be prescribed and dispensed from opioid treatment programs only, so only from a methadone clinic. The next medication is naltrexone, and for OUD, the evidence-based medication is injectable naltrexone, not oral naltrexone. And so this can be administered in primary care clinics, and a lot of primary care clinics have this, not all primary care clinics, but a lot do. And naltrexone is an opioid antagonist. And the next medication is buprenorphine, I think the one that most folks are familiar with. This is a partial opioid agonist, and it comes in a submucosal form that can be prescribed from primary care, dispensed from any pharmacy. And it also comes in an injectable form. There's a monthly and a weekly injectable form, and those can be administered in primary care clinics, although again, not a lot of primary care clinics have it, although maybe Nelson can let us know if the P&T committee has approved it at the clinic here. Because I did submit something to the P&T committee like 2 years ago to get injectable buprenorphine here. So hopefully soon you all will be able to do that here at Northgate. For those of you on Zoom, Nelson just walked in the room. Okay, and so all 3 of these medications improve outcomes. They increase treatment retention and employment, and also lead to decreased rates of return to use, HIV and hepatitis C incidence, and then methadone and buprenorphine, specifically, not naltrexone, just methadone and buprenorphine actually decrease mortality, which we don't have a ton of medications that really do that. So, I mean, these are truly life-saving medications. Oh, wait, go back one slide. Perfect. Okay. So, and so I want to kind of show you just, forward one more slide. Perfect. So, I want to show you just like the scale of how how life-saving these medications are. So this graph shows a standardized mortality ratio, which is the ratio that compares the number of deaths in a study population to the number of deaths expected in that population. And so the first bar is the general population. So their ratio is 1, of course, because it's the general population. The next bar is people with OUD who are not on treatment. And you can see their death rate is 6 times higher, super, super high. And then the next bar is people with OUD who are on buprenorphine or methadone, and their death rate is down to below 2. So it's, you know, a third of what the death rate is for people who are not on treatment. It's not as low as the death rate in the general population, but it's kind of approaching that. So we have very, very few, if any, medications that have this significant of a mortality benefit. So these are like incredibly life-saving medications. Unfortunately, there are some complicated regulations that impact the way we deliver these medications. So methadone for opioid use disorder is regulated by SAMHSA, the Substance Abuse and Mental Health Services Agency, and can only be prescribed and dispensed from a licensed opioid treatment program, so from a methadone clinic, not from primary care. While buprenorphine for opioid use disorder is regulated by the DEA and can be prescribed and dispensed by any person or any pharmacy that has a DEA license. There previously was a requirement to have a special waiver to prescribe buprenorphine, but that's been eliminated. So now anyone can do that. There are also some kind of complicated clinical considerations with these medicines that are important to think about. So like I said, methadone is a full opioid agonist. And in general, perfect. In general, it started at about maximum of 40 milligrams on the first day at a methadone clinic, and then slowly increased up to a maximum of like 60 in week 1, and then slowly increased to the perfect dose for someone over weeks to months. And that perfect dose is like, it could be 50, it could be 250. There's no like standard dose. Everyone is totally different. But there are really, really strict regulations about take-home doses. So it takes like many weeks to months to be able to not have to go to the methadone clinic every day. So super hard to start on these medications, and super hard, you know, to fit this in the context of a life if you're having to go to the methadone clinic pretty much every day. And you know, the reason for this is like methadone is a full opioid agonist, and like in my time, I didn't see a lot of methadone for chronic pain, but I think previously we saw a lot of overdose related to methadone for chronic pain. So people are worried about methadone, and there are some safety concerns, and so that's why we're so kind of worried about it, maybe a little too worried, but you know, that is why we worry about it. Because people can overdose if they're started at too high of a dose, or if they're increased too quickly. And I think the hard thing about methadone is everyone metabolizes methadone differently, and you just don't know how someone's going to metabolize it. So for some people, 50 milligrams is perfect. For some, you know, they need way higher, and you just can't know. So you kind of gotta, when you're in the outpatient setting and watching people really closely, you kind of gotta go slow. Things are different inpatient. You can start people and increase people much more quickly because you have your eyes on them and you're watching them closely. But you know, you have to be a little more careful when doing this from a methadone clinic. But we had a kind of bit of a naturalistic experiment with COVID about increasing access to methadone. So when COVID hit, all of the methadone clinics, you know, were like, wow, we probably shouldn't be having everyone coming in every day, all sitting together in this tiny room and giving each other COVID. And so they had some temporary changes in the rules that allowed them to give people more take-home doses and give them to them more quickly. And people studied this. And what we saw was that while overdose deaths, increased during that period of time, methadone deaths did not increase. So we had a real world example of, safely expanding access to methadone without seeing an increase in methadone overdose deaths. And then shifting gears to buprenorphine, which people are probably a little bit more familiar with. Buprenorphine is a partial opioid agonist with high affinity for the opioid receptor. And the implication of that is there's a risk of precipitated withdrawal if it's started when full opioid agonists are bound to the opioid receptors. And I'll talk about that in the next slide. But unlike methadone, buprenorphine is super safe. Like, you can give people a full dose of buprenorphine and it's safe. Like, there's not that risk of overdose that we worry about with methadone. So going back to precipitated withdrawal, this is like really, really complicated actually. And I think a lot of folks in healthcare don't understand this, and let alone patients. And so I think it's super important to have a good understanding of this, and even further, like, have a way to describe this to patients so you can talk with them about this when you're starting them on medications. Because if they don't understand this, it's going to be really hard for them to get started on medication. So basically in this drawing, in the first box is a person who has full opioid agonists on board. So those orange shapes could be heroin, fentanyl, methadone, oxycodone, any full opioid agonist. And the person is feeling a full net effect of opioids, and they're feeling fine. They're feeling normal because they have tolerance. And then you give them buprenorphine, which is the blue shapes. And since the buprenorphine has that really strong affinity for the receptors, it kicks off the full opioid agonist. So it takes over. And what you see is a rapid decrease in the opioid effect. And that's what leads to precipitated withdrawal. So you can see in the final picture, the person is having this big net decrease in opioid effect and is feeling really sick. They're diaphoretic, they're pale, precipitated withdrawal. And so really the hard thing with buprenorphine is, how do we start people on it without them getting precipitated withdrawal? And so before fentanyl, when everyone was using like heroin and oxycodone, we would say, okay, so just like wait 24 hours after using and then start your buprenorphine. And that worked kind of okay. I think most people were like able to do it. It was hard, but it was okay. But now with fentanyl, we're really seeing that people need to wait longer. They need to wait like 48 hours before starting on buprenorphine to not get this precipitated withdrawal. And this is super hard because fentanyl is like so potent, so strong, so short acting, ironically, that really people are just not really able to wait 48 hours if they're using fentanyl regularly. So we've had to kind of rethink the way that we start buprenorphine. And so this slide kind of, this is more of like a hypothesis theoretical slide trying to explain why we see this difference with fentanyl, because it sounds counterintuitive, right? Like, fentanyl is super short acting. Shouldn't it be short on, short off? Like, wouldn't the window of precipitated withdrawal be shorter? But that's not what we see. We see that it's actually longer. And we think that the reason that is because fentanyl is super lipophilic. And so if people are using really heavily, it hangs out in their body and their fat cells for a long time and has delayed clearance from the body. And so this diagram is from a study that looked at fentanyl clearance in folks who are using fentanyl heavily, and they found that it was like really 7 days until it was totally cleared out of the body. So this is kind of like our current hypothesis for why folks are at risk for precipitated withdrawal for longer when they're using fentanyl. So this is a picture that I made to kind of describe how I think about these new ways that we've come up with starting buprenorphine in order to avoid precipitated withdrawal. And this is how I talk about it with patients. And so the first way is a low dose start. And so with the low dose start, basically folks are continuing their full opioid agonists, whatever it is, and you're giving them a teeny tiny bit of buprenorphine. And then over the course of 3 days, 5 days, 7 days, 14 days, you're slowly increasing them to a full dose, to a point where their receptors are pretty much fully saturated with buprenorphine, and they can then stop the other opioids or decrease because they're not really doing anything. And so the way that I describe this is like if you have this cold lake that you needed to get into, the first option, the low dose start, is like tiptoeing slowly, 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 slowly into the lake. As opposed to a high dose start, the second option, which is where you essentially like wait as long as you can until you're in moderate withdrawal, and then you take like a full dose of buprenorphine, and you're probably going to feel some precipitated withdrawal. And then you can give people adjunctive medicines, just kind of try to get through it. And then 30 minutes later, take some more. And then if they're still not feeling better after that, 30 minutes, take some more. So you're kind of like, in this one, you're just like packing in the buprenorphine until they sort of feel okay. And then the next day they can go to a regular dose. And so this option is just like cannonballing, jumping straight into the lake. And so this is how I talk with patients about it. It's like, we don't know that like one way is better or worse, but like what works best for you? What would you prefer to do? I'll say most people choose the tiptoeing in slowly option. Okay. And so then this begs the question of like, okay, we have these two medicines. They're both really good, but they both have these like kind of complicated things that make them a little bit more challenging to start. Which one is better? And I think the answer is like they both have a really significant mortality benefit. So these are both really, really good medications. But you know, methadone might be easier to start in the era of fentanyl. Because you don't have this issue with precipitated withdrawal that you do with buprenorphine. And second, in clinical trials, methadone has been shown to have better retention and treatment pretty consistently. So I'm not saying this to say, oh, methadone is like so much better. I'm saying this because I think a lot of times in primary care, there's a lot of stigma around methadone, and people think that methadone is like somehow worse, but it's not. It's a really great medication. And I think as much as we can, we should try to like minimize and try to eliminate the stigma that surrounds methadone because it's a really good medication. And ultimately the answer is like the best option is whatever the patient wants, whatever, you know, is the best fit for them, their life, and their co-occurring medical conditions. Okay. Unfortunately, there are some disparities in access to treatment to these medications. So, you know, here in Seattle, we have pretty good access, right? Like if someone wants buprenorphine, they can come to primary care clinic, they can come to Harborview and see me, I can give them buprenorphine. If they want methadone, we've got a lot of methadone clinics around. This is ETS, which is our one of the biggest methadone clinics in town. It's a really good methadone clinic. They can go there to get methadone. So here in Seattle, we have both options. You know, I think it's a little bit weird that people have to go to different places for different things. I think ideally they would be able to get whatever they want at the place where they are, but at least we have options here in Seattle. But if you look at Washington State, unfortunately, there's not great access to methadone. So most counties in Washington don't have a methadone clinic. If you look at our methadone clinics, they're pretty much like on the I-5 corridor around Seattle. There's a few in Spokane, there's a few on the Olympic Peninsula, but most places in Washington, people just like don't have access to a methadone clinic, so they can't be on methadone. Next slide. And then if you look at the whole country, this picture is a little bit old, so there's probably some new methadone clinics now, but it's even worse. So like there's a ton of methadone clinics on the East Coast. It's like purely blue in some parts of the country. On the West Coast, there's like pretty good methadone clinics up and down I-5, although kind of missing part of Northern California. But then in the middle of the country, there's really like no methadone clinics. And this is the most craziest thing of all. In the state of Wyoming, there's not a single methadone clinic. Like that is wild. And so like it's it's just like we have this great medication, but there's just such poor access for folks who are outside of these super urban areas. And then there are also some complicated kind of intersecting disparities as well. So this is a study that looked at buprenorphine and methadone availability in New York City. I couldn't find a study for Seattle, but I imagine we'd see a pretty similar thing here. So basically they looked at buprenorphine and methadone availability by neighborhood, and they found that buprenorphine treatment was more common in areas with higher income and fewer Black and Hispanic residents, and that methadone treatment was more common in areas with lower incomes and more Black and Hispanic residents, and that this disparity worsened over time. So there's like some really complicated dynamics going on in across our country in terms of access to these medications. So this raises the question, at least I think this is a big question that I have, is like, why can't we just do this all in primary care? Like, why can't we do methadone in primary care? Primary care methadone is really the standard of care in a lot of other countries, including in Canada. We have a large body of evidence that shows that methadone in primary care is safe, feasible, and effective. And a lot of folks, patients, clinicians, researchers, and NIDA leaders, so the substance use branch of the NIH, have all called for regulatory changes that would increase access to methadone in general medical settings. So it's a lot of folks besides me who are interested in doing this as well. Next slide. Okay, so I just want to quote a couple people who I have a lot of respect for, who have talked in this area. So this first person, this is Ruth Pody. I'm a huge fan of Ruth Pody. She has no idea who I am. But she is a full spectrum family medicine doctor in Western Massachusetts who also runs a bunch of OTPs and buprenorphine clinics. She's a very, very engaging speaker. And she calls methadone a miracle molecule, which I love because it truly is a miracle molecule. And you can tell by her pictures. She's great. I'm a huge fan. Okay, we should invite her to talk sometime. Okay, let's do it. See, maybe she knows who you. Okay, let's do it. Let's do it. Great. Okay, and the next person, Nora Volko. Nora Volko is also, I have a lot of respect for her. She's the director of NIDA. And in a recent blog post, she said, yet methadone, the oldest and still one of the most effective medications for OUD, in our OUD treatment toolkit remains siloed. In the current era of powerful synthetic opioids like fentanyl dominating the statistics on drug addiction and overdose, it's time to make this effective medication more accessible to all who could benefit. I couldn't agree more. Okay, so there are a lot of folks who are interested in doing this, and there's been a little bit of movement in terms of doing a little bit of methadone outside of OTPs, and this has been driven by this 72-hour rule, which is this rule, this 21 CFR Part B rule that technically allows you to dispense 72 hours of methadone outside of an opioid treatment program in order to bridge someone to an opioid treatment program. And I know the folks like who work on FMS, like we do this a ton in the hospital, start people on methadone, discharge them with 3 days of methadone, and then they bridge to an OTP. And so a lot of folks have been doing that for a while now, and it's been working pretty well. And technically, we're able to do this from outpatient clinics too, but this has not really been done very much. But technically, we're able to do this. And so for the past 6 or 8 months or so, I've been working with a lot of folks from Harborview and also our pharmacists at Harborview. We have incredible pharmacists. And the Epic team, and we've been building out a protocol and an Epic order set in order to start people on methadone from our clinics. And so this hasn't gone live yet, but it's probably going to go live in the next couple of months, and we'll share information when it does. But this is so exciting. Like someone can come see me in clinic at Harborview, and I can say for OUD treatment, I can offer them all 3 FDA medications for opioid use disorder. So that's super exciting. And then the process will be that they'll go to the discharge pharmacy in the main hospital and they'll give them the medication. And then we'll have care coordinators and social workers who will schedule their intake at an OTP. So more information about this coming soon, but this is something that I'm really excited about. Okay. And there's also there's a bill that was introduced in 2023 that would also expand access to methadone. So MOTA is the Modernizing Opioid Treatment Access Act. And this bill would allow physicians who are board certified in addiction medicine to prescribe methadone from clinics. And so I think, on one hand, it's good. It's a good first step in terms of, demonstrating the safety and feasibility of doing this outside of methadone clinics. But I don't know how many addiction medicine doctors there are in Wyoming, right? Like it's probably not going to be enough to get methadone to the places where they need it the most. But I still think, like I said, I think it's a pretty good start. And there's been a lot of organizations who have been in support of this, including, ASAM, which is our big addiction medicine society, EMERSA, which is our multidisciplinary addiction medicine society. So a lot of folks have been in support of this. But there is one organization that is opposed to it, which is the American Association for the Treatment of Opioid Dependence, which is the professional organization that represents the methadone clinics. So, yeah. Okay, so yeah, go ahead. A lot of them are, but not all of them. Yeah. So like ETS here is the big one in Seattle is not, but a lot of them are. Yeah. Okay, so we talked about medications. I talked about methadone, and now I want to talk about what are the things like besides just giving medications that we can do in primary care to help folks with opioid use disorder. And I think one of the main things is just try to be low barrier. I think this is much easier said than done in primary care with all of the pressures that we have, but as much as we can, try to minimize the demands placed on patients and make services readily and easily accessible. Some examples of this are giving people same-day treatment with no appointment required, rapidly reinitiating medications after short-term disruption, and then continuing to offer treatment even when people are continuing to use. And then reducing stigma. I think this is all something that we're all working towards. And, stigma can be present at the societal, institutional, personal level. And really, stigma is just a set of negative attitudes and stereotypes that can create barriers to treatment and make conditions worse. So we know stigma can make people who need care less likely to seek it, make people fear disclosing substance use, lead to poorer quality of care, and reduce access to treatment. And then finally, I don't know, I feel like this is actually maybe the most important thing. It's just like be a welcoming place. So you could do this by displaying pamphlets, posters, lanyards with other with positive messages about people who use substances, having peer support services available, so people who have lived experience with substance use. And then offer people water, snacks, and other things to help them meet their basic needs. And I think really the most important thing that we can do in clinic is make people want to come back. Oftentimes, it takes people 4, 5, 20 visits to start on medication, right? Like it often doesn't happen the first time. So if you just like are a welcoming place that people want to come back to, that is a success. And so I urge you to just think about that when you're trying to help people. Just make them want to come back and see me again, and then you're doing a good job. That is all I have. Would love to hear if anyone has any questions, comments. And then I also have some questions here if folks want to offer me their thoughts on that as well. Thanks, guys.
I can start with a question
Okay.
online.
Who's
Someone
it
was,
from?
pardon?
Who's it from?
It's from Barry Saber.
Okay.
Kind of summarizing the question, it's about bupe saturating the opioid receptor and how, like, kind of understanding if there's perioperative pain, why we add regular opioids and how does that work if they're like the buprenorphine is supposed to be a stronger binder? Like,
Yeah, that's a good question. So again, this is kind of like, we don't totally understand everything. This is kind of hand wavy, but the thought is that you get someone to like 16 milligrams, then that's like something like 80 something percent, something like that. Most of their receptors are saturated. And so that's why people generally like feel okay when they're on 16 milligrams, but there's still a little bit left. And the thought is that in terms of acute pain, we used to recommend that people would stop buprenorphine before they needed a surgery something, but now we know, and we have seen that it's okay for folks to continue their buprenorphine and they just get extra opioids on top. They can get extra buprenorphine or they can get like extra full opioid agonists. And but because they're on the buprenorphine, they're going to need higher amounts than someone who isn't on buprenorphine. So they're going to need much higher amounts of the other opioids in order to overcome the buprenorphine. Did I answer that question?
I think you did.
Okay. It was about perioperative pain control. Okay. Yeah. Anyone want to comment on any of my discussion questions? Oh, actually, I have a question. Okay, who here is prescribed methadone for OUD? Yeah, okay. Who here is, and you can not answer this question, but who here has ever like been inside a methadone clinic? Yeah, so I think this is a big problem with our medical training that is a side effect of methadone being siloed is we're not teaching people how to do methadone. We're doing a better job now in hospitals because we're doing it in hospitals, but we're not teaching people how to do methadone outpatient. And unless you do an addiction medicine fellowship or are, do extra addiction medicine training like Sebastian and I have, you'll never learn how to do methadone. So it's this big like mystery thing that like no one really understands. And I think that contributes to the stigma. And so I'm excited that our residents are learning more and more about methadone, and I hope that we can continue that and include some training in methadone clinics as well. Yeah, Muriel.
Very, like you highlighted, I've never been inside a methadone clinic, but have, prescribed methadone for folks inpatient to start. I was wondering for the methadone clinics and how beneficial methadone is for mortality more than buprenorphine. I'm wondering if part of the effect is also like there is a really structured way that people like that you can have a really structured day to day. And I wonder if there's like a community that's built through having a place that you go to where you share similar like desires and values of why you're using like
Totally.
yeah, and through prescribing methadone and like the outpatient, like through primary care, is there a way to preserve that sort of community building?
That's a really good point. Like I think we often think that people don't like going to methadone clinics, but there are a lot of people who love going to their methadone clinic. And we're just not seeing them because they're just like happy going about their life, going to their methadone clinic, and it's working well for them. I think that's a key thing in substance use treatment is like oftentimes the people who are doing super well, like we're not seeing them, we're not hearing about them, but they're out there, they're among us, they're everywhere. So a lot of folks do like methadone clinics. They appreciate the structure of them. And a lot of times they're offered counseling, hepatitis C treatment. I did primary care at ETS, so a lot of times they're doing primary care embedded in methadone clinics. So while there's a lot of like things about methadone clinics that are not great for some people, there are some things about them that are really great for other people. And that's why I say like I don't think that one of these medications is better than the other. I think it's just like depends on the person, and we should try to make all options available for all people.
This might be like pharmacological nuance question, but in regards to Suboxone and like the combination of naloxone with buprenorphine, what's the benefit of the naloxone piece?
That's a great question. That's a great question. There is no benefit. So, okay, so there's buprenorphine naloxone is Suboxone, and then there's buprenorphine monoproduct which is Subutex. And so so basically when you take Suboxone, the one that has buprenorphine and naloxone, the naloxone has zero bioavailability. So when you're taking it through your mouth, you're not getting any of that naloxone. It's doing absolutely nothing. The reason it's there is because it's like a deterrent to keep people from injecting it, which I philosophically have a problem with, right? Like, why do we need to be like, it's kind of, I think it's kind of stigmatizing to feel like we need to do that. But that is the standard, is to give that medication. And a lot of insurance companies like won't cover the mono product. They'll cover it for pregnant people, but they sometimes won't cover the mono product unless you've like shown that people have had, there's a reason that they can't take the combination one. I have patients who are like, oh, I get like a rash, or I get this, or from the naloxone, and like maybe that's true, maybe it's not, but I have a pretty low threshold to like, if people say that they want the mono product, to give them the mono product. But that's just my practice. I think in general the standard of care is to give the combination one. And I think a lot of times, and this is why it's so important to understand precipitated withdrawal, a lot of folks think that that precipitated withdrawal has to do with the naloxone, but it doesn't. The naloxone really should not be doing anything. Yeah, great question. Yeah, Nelson.
Thank you for your advocacy for these underserved patients. And I think that slide that showed the mortality benefit was really illuminating. I was just reading that this week, SAMHSA is going to lose 50% of their budget, and many staff will be fired. And in light of this, I think primary care, obviously, we continue to help in this regard. How would you advise us to balance the sometimes competing goals of low barrier with difficult to manage addiction patients? I think of one patient of mine who she doesn't show up for her appointments. She asks for refills, and these are patients in which in primary care traditionally we have referred to addiction medicine. But if the resources are constrained, how can we better be equipped to help these more challenging addiction patients?
So I think, yeah, that's a great question, Nelson. I think I think that it's because like this is our job, right? Like I often hear people say like, oh, I can't do that because it will take over my practice. But like, we would never say that about diabetes and hypertension, yet like diabetes and hypertension are taking over our practice, right? Like we are primary care, we are family medicine doctors, we take care of like all parts of people. And this is another chronic medical condition. And so I think we need to find a way to do it. So I think that's the main thing, is like, we need to do this. And second of all, going back to that thing that I said earlier about there being a lot of people who are doing well. So I've been doing, like, my panel is predominantly people with substance use disorders, and I love it. It's, I mean, there are very few things that we do in primary care that actually like make people's lives better pretty much immediately. But getting people who are deep into OUD, stable on medicines, their lives get better. They, reconcile with their families, they go back to work, they feel better. Like it's truly so incredibly rewarding. And I think in this era where we're all like kind of a little bit burnt out and things are really hard, I think it's actually like one of the like things that we can do that will help fulfill us in our work. And then once you do this work, you start to have a lot of patients who, like, I have a lot of patients who are like, came to me very deep into their addictions and now are like thriving, living their best lives, doing super well. So I think, people oftentimes it's we got to be low barrier and work with things at first, but like once people get stabilized, like it's oftentimes like kind of smooth sailing. Might take 20 tries, but once you get there, there's a lot of people who are just doing super well. Yeah.
Zoe has
Oh, Zoe Taylor. Hi, Zoe.
Hi, I'm so proud of you. You're amazing.
How are you, Zoe?
I wanted to just address your discussion question. So I graduated from the amazing UW Family Medicine program, and I'm doing a lot of addiction medicine work in Whatcom County. And so I encounter this. I'm really glad these are your discussion questions. And I guess from my perspective, I've done a lot of talks like this and trying to convince local primary care doctors to start prescribing buprenorphine. And there are some people, where I feel like we've made a difference and we've inspired them, but there's so much resistance still in family medicine to doing this work, because in the real world, also they have to worry about like insurance mix and all these things, right? So they're worried about their practices being taken over, just like you said. And I was wondering, I know that like Ying, for example, is doing so much work with abortion, which is, I think, similarly stigmatized, to have UW and Harborview like help teach, rural clinics how to do that. And I was wondering if there are any programs at UW or Harborview in a similar model to like create networks to help doctors in like Whatcom or Skagit, where the problem is really, really bad, learn how to do this work and kind of help support them in doing it. I mean, we're doing that work locally with like our local county health department. For sure, we're doing a lot of work, but I think having UW support in that would be really helpful.
Yeah, I agree. I think there's been a big movement to expand echoes, like addiction medicine echoes. And so I think there's a lot of echoes available. I think, and we also have like the hub and spoke model that's been pretty disseminated in our area. So I think there's a lot of things out there. I think the hard thing is that those things, like they just reach the people who like sign up or the people who want to do it. And so I think the hard thing is like, how do we get this everywhere, even to like the people who are like not as excited about doing this work? I think that's the harder thing.
Yeah. I think people know who to reach out to if they have questions, like if they start doing it and they need help. Like UW has like hotline, there's the pain hotline, there's the psych hotline, but I think it's more like if there was like a traveling band of inspiring speakers who could come, like we're happy to do it too, but I imagine every county in Washington is trying to do the same thing.
Great grant project, Zoe.
I think your clinic is doing like really cool, innovative things. So I'm happy to come talk more. I also think that you guys could do methadone from your clinic, potentially. So I think you guys could do a lot of cool stuff. But yeah, I think that this is why I'm just like always talking about this, right? And I think like I think a key message that I try to send that I think is the most important is just how fulfilling it is to do this work. Because I think that's what a lot of people are worried about. But just showing people how fulfilling this is to do this work, I think can sometimes be the one of the more powerful things you can do.
Could I just quickly ask a question
Yeah.
that I think is related to that, which is how important has it been, the team you showed in the beginning, how important has that been to this being enjoyable for you? And related to Nelson's question about the perceived difficulty of patients, and how is that, how are teams like that funded these days?
Yeah.
Hi, Zoe, it's Val.
Yeah. So so it's much easier if you have a team. Like at Harborview, when I start someone on buprenorphine, Kira is our OBOT nurse. And so I'll message Kira. Kira will come up, do a warm handoff. Kira can call them the next day, check in, let me know how they're doing, tell me if they need refills of meds. So I think it's a lot easier. And that helps with the kind of like low barrier thing. Cause like sometimes like we can't, as PCPs, we can't see people multiple times in a week. We can maybe see them the next week, but it's still hard. But so having those people to help you and support you is, I think, really helpful for the PCP and also for the patient. And I think it can be an OBOT nurse, like we have an OBOT nurse at Harborview, but I think in different places, depending on your staffing, it can be different people. It could be a nurse, it could be a social worker, just someone to check up on the patient and see how they're doing.
I'm going to add a comment to that because I think often it's seen as a barrier to starting buprenorphine when you don't have a support system. And I've just been in places where like we call it no longer medication assisted treatment. It's medications for opioid use disorder because you don't need necessarily all the ancillary services, right? Like you can still do it without, and it's harder, but like it's kind of like doing diabetes care without the educator, without the pharmacist, without everything, but it's still doable, I think, right?
Yeah.
But just not ideal.
Yeah. Yeah.
Thank you so much, Claire. This is follow-up of Nelson's comment, and I hear the gratification that you feel, but if we're going to advocate and be effective in advocacy, what would be the places that we could be better advocates, either politically or within the health system, insurers? Because I'm sensing there are barriers on the insurance side, maybe barriers on the governmental side.
Yeah.
Where do you sense that allyship can be built?
That's a great question. I think we do have a lot of allies. Like the folks at SAMHSA are incredible. They're really supportive. So I think that we have a lot of allies in this work, and I think that things are going in the right direction. I think to Zoe's point, I think what we need to do is like we need to find a way to reach the people who are less interested in this. The people and these are probably the people who are working in the areas where they need this the most. So I think trying to reach rural areas, folks in rural areas, and try to sell them on this, I think is important. One thing that I think we can do is try to get injectable medications. I think like, from psychiatry, we know that like injectable medications are kind of just better for people whose lives are kind of chaotic, like people with serious mental illness or people with substance use disorders. So I think that's one thing that's like kind of low hanging fruit, is making sure that all clinics have naltrexone and injectable buprenorphine. And I think that's something that we could do as a health system, and is super doable. Because, I think it's gonna take a while for methadone to, if ever, to get to Wyoming, but it's like we could at least get injectable buprenorphine there, and I think that would be a good start. I don't know, Sebastian, do you have any other thoughts about ways to advocate?
I think it's making sure that trainees learn about it, because I think the evidence
Yeah.
has shown that people who are recent graduates went to programs where there is exposure to addiction medicine are then likely to go out into practice. So making sure people who are trained in rural areas and are WWAMI residencies learn about this is maybe on a local level or regional level what we can be doing, I think.
Yeah.
Is it okay if I just add one more thing? I think the thing that really needs to happen though is leadership to leadership also of these clinics and networks, because I do see actually a lot of new grads who got the training coming to Bellingham and then feeling like they inherited a panel that this isn't relevant to, and working in a clinic that is not welcoming to these patients. And so it doesn't help that they got the training. So I think we're doing a great job of training residents, and that's huge. But the leadership of like Multicare, Sweet, like all these big entities, and also places like Family Care Network, have to be on board in order to give their providers the opportunity to do this work.
Yeah, I want to just echo that. This is Carrie Stevens online, you guys. And I think hey, Claire, I think there's also barriers. So advocacy is needed for states, particularly some states that, for example, didn't go through Medicaid expansion initially. They have different ways of billing. So I've been in Idaho and sat with providers who are very excited to do this care, and then here their administration walks over and says, "No way, we're not doing this because we don't have a way to get reimbursement." So I think there are still perceptions or longstanding administrative issues with people getting reimbursed that we need to break down across states too.
Thanks, Carrie and Zoe. I know we're almost out of time. Do you have any last words you want to say, Claire? Great. Well, thank you so much, Claire, for coming and speaking to us. If you have a moment, please go and fill out the feedback form in the QR code. And then next month, we actually won't be here. We'll be in the South Campus Center location from 12 to 1 with Dr. Michael Mintz talking about value-based care. That will be the first hour of our DFM Scholarship Forum and Fair. So thank you so much for coming, and see you next month.